thank you so much for coming on today, Bridget. I couldn't think of anyone better to have this conversation with. We've obviously spoke a few times on the phone now, which I really, really appreciate about the work that you're doing and the conversation that we need to have, and specifically why it's so amazing that you're here today to share it with potentially a slightly different audience, and why that's going to be relevant for some business owners and some people in the fitness industry. But just before we start, I'd love to just read off a couple of the statistics that you sent me from your own research, just to like set the tone for this conversation, if that's okay. So there were many very powerful stories and statistics on the surveys that you sent me. These are just three that for me really stood out. And the reason I'd like to share these to start this conversation today is I think as men, we can often think, can't be that bad. You know, what are they kind of going on about, right? Because we just don't have these conditions. And maybe even some women, if they're lucky enough to not experience some of these conditions, there's some women that I know that are like, can't be that bad, right? So just to set the tone a little bit, with the survey that you sent me, 77% of the women you surveyed scored at least an 8 out of 10, so an 8, 9, or a 10 out of 10, on the impact that their female health condition had on their quality of life. And only 1% were 4 or less. So virtually all of these women were at least a 5, and the vast majority, 3/4 and above, were an 8 out of 10. So this is like a severe impact on quality of life, right? So, I mean, we could just use that one statistic, and that is the foundation for needing to have this conversation. But just a couple more that I thought were really powerful. The majority of the women you surveyed, I didn't actually even want to count how many, said that it took 6 or more appointments to get their diagnosis. And I just can't comprehend that with the current NHS waiting times, 6 appointments can obviously be years and years, right? And I just can't comprehend the extra stress that causes, which of course can make conditions worse. You've got the compound effect of not getting the right treatment, which is going to make these conditions more severe. So that was, for me, really sad and really powerful. And one that is potentially the most relevant for what you're doing, and we're going to talk about, not that to detract from the impact on people's lives at a personal level, which is of course the most important thing, but something that also needs to be addressed is the issue this is having on the economy and for companies, right? And 13% of the women you surveyed said they took at least 9 sick days a month from work, which, I mean, that's 2 working weeks, really. It's 50%. And that's actually a little bit worse than it sounds as well, because a lot of these women said that it used to be more before they got their diagnosis. And some of them also said that they don't actually work anymore. So I think for anyone still not entirely sure, like, is there a problem here? Is it that bad? What is the gender health gap? Hopefully those statistics show that we have this problem here that isn't really being spoken about. It's not really being researched. It's not really being funded. And it's having a massive impact on women at a personal level, at professional career development level, and it's also having an impact on companies and on the economy. So with all of that being said, I couldn't think of anyone better to speak to about this than yourself. So thank you so much for being here. So yeah, Bridget, over to you really. Tell us a little bit about who you are, what you do, and obviously your backstory and journey that took you here today to be conducting work like the research that I just quoted there.
Yeah. No, thank you so much for having me. I think it's a really important conversation to be holding. So thanks for giving it this platform as well. So my name is Bridget Gorham. I'm a health economics policy advisor at the NHS Confederation, and I'm currently undertaking a pretty wide study focused on the relationship between investment in women's health and wider economic growth throughout England specifically. So I think there's no like one moment where I can really point to that indicates how I kind of followed this trajectory. I think I've always been quite passionate about equality. I'm a middle child, so I think for as long as I can remember, I've always wanted things to be fair. Once you start seeing inequality, it's kind of like you have these goggles on and you can't stop seeing it. And I think having joined the NHS Confederation with a specific focus on health and the economy, women, I think, making up half the workforce, 80% of the NHS and social care workforce. I mean, I think it's a huge kind of group of people, if you even want to call it a group. It's half of the population that's consistently overlooked, ignored. And health is a fundamental human right, even if we take the economy out of this conversation. I think it's just such a shame and really a kind of human rights violation almost that women don't have a standard level of care that they need and deserve. And so I'm really passionate about women's health, but also I think in addition to the moral kind of arguments that we can make about this, the economic argument is probably in this climate of austerity what's really going to shift the dial, I think, and really kind of bring to the table some leaders from the Treasury and central government around what we can do in a time of, like I said, economic kind of austerity and stagnation. So yeah.
I love that. The reason why I love your work in particular and just how you worded it there is that we should not have to reduce female health to a number. Of course we shouldn't have to. But one common kind of theme that I was hearing, like one thread throughout a lot of the talks and seminars that I was going to, and I've met you at some, which is amazing, was that, okay, if businesses are going to support their female employees with this, like ultimately how does it translate to their bottom line? Because a lot of companies are struggling. So whilst it is unfortunate that we do need to look at it from this perspective, ultimately if it helps change education at a societal level, if it helps more women get supported, then ultimately, is it a bad thing to look at it through this lens? And whilst me and you are really confident to sit here and say investing in women's health is a great investment, we know that there isn't really that research out there conducted in a way which allows us to quantify and provide like a number, right? Which I think is obviously what you're working on at the moment, is to be able to say for every pound spent on women's health, we get this return on investment. So I absolutely love that, because as you've just said, it hopefully is what will be needed based on this current climate to actually really push this landscape forward. And I think in a few years' time, we're going to look at the landscape and it's going to be very different. And that's going to be largely down to the work that you've done, which is exciting, isn't it?
No pressure.
No pressure. You're already living up to it though. So I think you'll hit it. So yeah, I mean, just to give us a little bit more backstory on yourself and maybe going as far back as you'd like, your childhood or your upbringing, your qualifications. You're from, was it Chicago initially?
Boston.
But it was Boston. Sorry, yeah, my bad. So yeah,
big mistake. No,
give us a lot of beef there.
So I was born and raised in New England and in the U.S. I did my undergraduate degree in political science and Spanish. I spent some time during my undergraduate degree in South America. So I lived in Quito and Cusco for a while, and there I volunteered at 2 local schools, which was really nice and just really eye-opening, again, looking at this from a gender lens. Some of the inequities there in terms of girls having the kind of fundamental right to an education. And so that really, again, you have those inequality goggles on all the time, and it's just like it really left an indelible mark on me, seeing how so much of kind of the populations that I worked with really struggled to access a fundamental human right to an education. I then took a kind of conventional route out of undergrad, if you will. I went to work in consulting at Deloitte for 4 years. And at the time, it was a very sexy career because it was like I was traveling every week. I worked in sales and trading, so the banking, capital markets industry. And then COVID hit, and I wasn't traveling anymore, and it really allowed me, alongside probably the rest of the world, to pause and reflect on, what it was that I wanted to be doing with my life, and whether I thought this was where, consulting was where I could actually leave an impact. And those experiences in South America really stuck with me. And so I started to explore degrees in human rights, which is how I found the program at the London School of Economics. So I applied, was accepted, moved over to London, did my master's in human rights, which was amazing. It was such a great program. And I really liked it because it was like a practical approach to human rights. So not just the theories around it, but like how this works in reality. So a lot of human rights law and international criminal law. And then it was a really interesting and kind of a bit of a struggle trying to bridge the gap between banking and finance and human rights.
Yeah. Somewhat contradictory sometimes.
Yeah, exactly. And so I was like, I don't really know how I'm going to do this. And then this position in health economics popped up on LinkedIn, I believe it was. And I thought that's quite an interesting bridge between the two worlds, because obviously you've got the economics lens to a kind of critical human rights issue. And so in my mind, it made sense. And to, my now current boss's mind, it also obviously made sense. And so that's how I ended up in the role I am now. And so for the first 6 months in the role, I was really focused on kind of figuring out what the NHS does, how it functions. And I can't say to you that I've entirely figured that out. I don't know if many people have.
No one knows.
Yeah. Yeah, so it was really the first 6 months was getting my bearings and working with my colleague Michael Wood on a whole host of pieces that were assessing the relationship between the NHS and the wider economy. So we published a piece surrounding the return on investment for every £1 that goes into the NHS. The piece found that for every £1 that goes in, you can expect to see £4 return on investment through increased workforce participation and productivity. We then delved into that figure a little bit more and looked at investment across a range of care settings, so community, primary, acute, and mental health care settings. And we found we kind of, it was almost like what everyone was saying, right? Prevention is a more economically effective way of approaching health and care. But we quantified it. We were able to show that for every £1 that goes into primary and community care settings, you can expect to see £14 return on investment. Whereas I think acute was still relatively high, but it was less than that. So it kind of substantiated what we had been saying historically around, prevention is where you want to be putting your pounds. Because obviously down the line, acute care is much more costly, reactive, etc. And then I believe it was in March of 2023, so almost a year ago, when the Department of Health announced £25 million in funding for the establishment or expansion of women's health hubs throughout England, which really struck a chord with me. I think it was a really natural opportunity to start pursuing a bit of a niche, if you will. If you even want to call it a niche, I don't know, because again, it is 51% of the population. But I thought it was interesting when they announced the funding that they stipulated that it wouldn't be recurrent. So it was very much a one-off lump sum, quite a minimal amount of funding as well. I think in the headlines, everyone thinks, £25 million, that's a ton of money. But when you're thinking about half of the population, it's really not that much. Particularly when you divide it equally across the 42 integrated care systems. Each integrated care system received just under $600K to basically establish a women's health hub, which are intended to be one-stop shops for women's health needs. So in theory, you could go into a hub, have a coil fitted, have your blood pressure taken, and have a smear performed. Whereas today, those are 3 separate appointments with 3 separate kind of commissioning styles. So sexual health falls under the local authority, and then obviously your smear would be through your GP. So it's meant to kind of liaise all of those different services, which in theory is a really great idea. Yeah. And it's kind of what I know you do a lot of work around holistic health. And I think that's a really great step in the right direction of like seeing women and people generally as, whole creatures that have a whole host of needs, and really you're saving a lot of time if you're able to do a whole host of those things in one appointment. So essentially, yes, they announced the funding. They stipulated that it was non-recurrent, and I kind of then started to look into the economics of this. Like, how can we make the case to Treasury that this is something that not only needs to be sustainably funded, but also robustly funded? And there was a kind of a dearth of evidence around the economics of women's health. There were some very specific studies on kind of the return on investment of a specific kind of femtech technology maybe, or endometriosis and the costs to the economy. But I found two kind of common themes throughout the existing research, one of which was that it was very siloed. So it was very much like, a specific condition like breast cancer, for example. And it didn't really look at women more holistically. It looked at specific issues that were very siloed. And then the second bit was that there were oftentimes quite cost heavy. So they focused on the cost of a specific condition to the economy through what you mentioned at the onset of this podcast. Missed days of work, lower productivity rates, and things like that. But I think the twist, and this is what my work intends to do, is really show the potential for further investment in this space. Because I think when you say, for example, that endometriosis costs the UK economy, whatever the figure is, I forget what the actual number is, like certain kind of couple million at least quid a year. It seems like it's a really big problem, which it is, right? But it's also interesting, particularly in the realm of women's health. If we think about a lot of these conditions, some of the kind of investments that we can make are so minimal. I mean, in certain cases, yes, we need much more kind of advanced technologies, which will require robust investment. But when you think about a common theme that came up in the survey as well, was that women are just not being listened to. So the six GP appointments, or the 6 appointments to get a diagnosis, that obviously costs the economy, because it's, a costly referral, or, another wasted appointment. And those types of things can just so easily be avoided if we're listening to women, and that's free.
Yeah, there's no innovation needed there.
Exactly. So yeah, hopefully that wasn't too long-winded of a synopsis of my work.
Yeah, no, that was really great, and yeah, I'm so excited to see it. Obviously, coming from the space that I come from, a large part of what we do has to be translating that work into a bottom line, unfortunately. Of course, we do work B2C as well, where that's no longer relevant, but a lot of people do still want to see, okay, if I'm going to invest this money in my health, I want to feel better and look better, but ultimately I also want to be maybe a better performer if they're in a performance-based career role, or if they just have a lot of career aspirations, right? So even when we're working B2C, it's important to try and have this research if possible. So yeah, I'd love your work. What I think would be great is to go back a little bit further, if that's okay. So obviously, me and you are going to be aware of like, why is there a gender research gap? Why is there a gender health gap? And I kind of take for granted that makes sense to me. But a few recent conversations I've actually had, which I found really interesting, were like, that sounds ridiculous. How could we be in England, what's it like, the 6th most developed economy in the world? We have the NHS. How and why could women be receiving a worse standard or level of healthcare? And I thought, you know what, that's actually a good question, because it potentially doesn't make sense at first if you're someone that isn't aware of what we're aware of, right? So yeah, going back kind of historically, how have we ended up here where we have this gender health and research gap?
Yeah, so I think it's at the heart of this issue is that we have always lived and continue to exist in a patriarchal society. So medicine and the NHS itself were built and founded by men for men. Studying, it's kind of the male default permeates everything, from medicine to even seatbelts. If you've not read Invisible Women, I highly recommend that. It's such a good read. But I think women and our bodies are consistently seen as like an aberration. So we may have, I've thought about this a lot recently too, in terms of like maternity. There seems to be a lot of research into maternity. not enough, obviously, but that seems to be an area that has more than others. And that I think is just like an obvious area as to where women differ from men. We bring life into the world. But there are so many other kind of quote unquote invisible conditions that have been sidelined, siloed, not talked about enough. And I think that has historically created the gap that we live in today, in that these topics, first and foremost, are taboo, still very taboo, even though more and more people are open about them, talking about them, advocating for change. And that obviously doesn't help it. If we're not talking about it, the gender health gap will continue to exist. But also research. Research is a huge thing, and disaggregation of data. So sex disaggregated data is also important and historically hasn't always been prioritized. And so back to the point about women's bodies and kind of looking into the aberration of women's bodies, I think there are some kind of clear instances where women are different from men medically, but there are also, for example, a number of conditions that affect men and women alike, albeit differently or disproportionately, like heart conditions, autoimmune diseases, so on and so forth. And we've not historically prioritized disaggregating the data and the research. We've not, I forget the statistics, but around like testing animals, and research, it's been predominantly tested on male mice or animals or whatever.
I saw that only 34% was conducted in female mice in cardiovascular disease. So the majority of those recommendations are being applied to women, but coming from male rodent studies.
Yeah. So why are we here? I guess my one-line answer would be because we have always lived in a patriarchal society. And we continue to live in a patriarchal society. So I think that just speaks to the point that this is not just a women's issue, this is a man's issue as well. And that's why I'm so grateful for you for kind of having this platform and also advocating for change, because men also have a big role to play in this agenda.
Yeah, thank you. Yeah, I mean, I obviously agree with you on that for sure. So yeah, I appreciate you saying that. I think that sets the tone really, really nicely, and that's really insightful. With the current work that you're doing and the meeting that you had yesterday, is there anything from that you can share that you'd like to let everyone know about kind of what the next few months look like for you?
Yeah. So I can share because there were press releases, so it's all publicized now. So yesterday I attended the Women's Health Summit, which was led by Dame Leslie Regan, the Women's Health Ambassador for England, Victoria Atkins, who's currently the Secretary of State for Health and Social Care, and who else was there? Lucy Chappell, who's the Chief Exec of the NIHR, and there's someone else really important who I'm just blanking on currently, but let's go with that for now. Maria Caulfield, the Minister of the Minister for Women's Health and Mental Health. So those were the four kind of key people there yesterday. And they made a series of announcements. So first they reflected on the kind of progress that the Women's Health Strategy has made to date. So they mentioned things like HRT being much more affordable. They mentioned women who have experienced pregnancy loss having more support in the workplace and beyond. The women's health hubs they mentioned as a kind of win for the women's health strategy as well. So lots of reflections and then plans for the year ahead. So I think the biggest announcement was £50 million in funding for maternity research. So yeah, that was really good. I think Victoria Atkins is different to her predecessor in that she is a woman, and she's had personal experiences of this gender health gap in maternity care specifically. So it's something that she's very passionate about. I think what was interesting is that they did announce a whole host of new services, like all women being offered an appointment, a GP appointment at 8 weeks after giving birth as like a standard approach. I didn't realize that wasn't a standard approach. It's quite disconcerting, but okay. Mental health support for women who have just given birth. So that it was very pregnancy focused. She did also say, and I'm quite curious about this, she said that each system, so each of the 42 integrated care systems would have at least one women's health hub, which is very interesting because obviously I mentioned the funding that was announced in support of the establishment or expansion of women's health hubs, but in response to NHS England's call for systems to break even for the financial year, a lot of systems ended up rescinding that funding. So they no longer have their $595K to establish a women's health hub. So I'm curious, a common theme throughout is like, this all sounds great, but how is it actually going to happen in practice if there's no additional funding announced? I mean, the research funding is great. And I think research is obviously important because there's a gender research gap as well, as you mentioned, but the services element of it and the training and how what we find from the research is actually implemented on the ground is equally important. If we don't have the resources to do that, then it's kind of a moot point.
Would you say you're optimistic about the work you're doing helping to find that investment once you can prove that it's going to have a positive ROI?
Let's see. I mean, what's interesting, and I know we've talked about this in the past, is that at almost every conference that I go to, people say we really need this argument. We really need these numbers and the kind of the quantification of the business case, if you will. So I am optimistic that it will be useful. The extent to which it can actually persuade the Treasury, let's see. I think oftentimes at a high level, those decisions can be really difficult, especially when the kind of national focus is it's centered on, acutes and emergency care and just putting out fires consistently. I think what's interesting is where local leaders can have a real impact in this agenda. So when push came to shove and integrated care boards were sitting down and figuring out how on earth are we going to break even for this financial year, what can we throw at the black hole to kind of, to achieve this? There were a lot of conversations where leaders were actually saying, no, we need to protect the women's health money.
Amazing.
Locally, yeah. And I think this type of argument could really help local leaders to defend and kind of make the case and, convince others to think more long-term and recognize the value of women. Because at the heart of this, I think, is truly that we don't recognize, the extent of the problem, which you mentioned at the start, but also the value of women and how on earth can we quantify the value of women? Like, obviously we can look at the workforce, right? And that's the most conventional route. But there's so much going on beyond that. So looking at the women's roles as carers, and that's not typically factored into economic arguments, the kind of informal labor element to it. If you think about generational health and the fact that healthier women have fewer and healthier children, and that kind of just passes on through generations. And there are just so many intangibles. And, I almost like to think of it as an onion, and there's so many different layers to the onion, right? And, I mean, so women in the workforce is a huge one. Women in the health and social care workforce is another one that is so often overlooked because I feel like consistently in the news we're talking about the NHS having workforce issues and a workforce crisis, and it's just like, well, 80% of that workforce is women, and what are you doing to support the women? The NHS long-term workforce plan didn't mention the menopause once. And we know that women are leaving the workforce due to the menopause at unprecedented rates. 1 in 10 women are expected to leave the workforce due to the menopause. It's such a missed opportunity, I think, to really show women that we recognize they exist and they are instrumental, pivotal in our kind of workforce and our wider economy, but also just to be a more inclusive employer.
It does. It blows my mind because I fully appreciate there's limited funding. You need to put out the fires, as you said, and it's hard to zoom out and think generationally. But when you have the situation where 80% of the NHS, and I didn't know this, 80% of the NHS workforce are women. And we know from your research and from there's some other studies, I think that there was a really big study done in Holland, right? It had 40,000 women in it. That in your one saying that, okay, so a large 13% of women are taking 9 sick days per month, which is half their working week. And then you're saying 1 out of 10 women are dropping out of work due to menopause symptoms. I believe the amount of women that are contemplating it or looking for a career change in menopause to help manage their symptoms is even higher, right? I've seen a few studies on that. I imagine that's maybe around more flexible or remote working to help manage menopause probably. So for me, it's a real simple 80% of the workforce are women. We know there's research showing that these women are unable to work or are dropping out of work due to these health issues. We've got an underlying issue in the NHS. Surely addressing women's health is what the foundation of the NHS therefore is.
Yeah, 100%. I couldn't have said it better myself.
I just wanted to say it out loud like that to make sure that like I was understanding the situation correctly, because it just sounds ridiculous.
It is absolutely ridiculous. I mean, I was on a call a few weeks ago where some NHS employees, women, were talking about how to get free period products in their workplace. I mean, if
the NHS doesn't supply period products.
I guess so not as a whole. It would be based on the trust or the hospital that they're working in. But it's not standard practice. And if you think about it, if you're in the kind of the operating room and you flood, and think about it, we live in London. Think about remote hospitals. Where's your closest shop to get period products? Like probably, I don't know, 15, 20-minute drive. So I mean, it's just really simple things that we could be doing to better support women, to illustrate to women that we know they exist and they have their own needs. It's just such a missed opportunity.
Yeah, yeah, crazy. So I've one of my clients is the head of haematology at 2 hospitals. Great guy, great doctor. And our version of the NHS app in where I'm from has a different name to it because of, I'll probably get the story wrong, so please no one quote me on this, but someone sitting on a board didn't like the name, or there was some sort of comment or whatever. So he's like, the amount of people that I deal with that don't have access to the app or think they can't find the app because it has a different name. And and you're just like, what are you even saying to me? Like, this makes absolutely no sense that like there'd be a different version of the NHS app with a different name that I would log into as a patient to view my results that I wouldn't know how to find or look for, because everyone else in the country and the standard recommendation is the app's called this is where you go to log in and view your patient portal. But yeah, sorry, that just popped into my head. But yeah, it's a crazy landscape. We'll definitely try and end the podcast episode on all the positive things that are happening and the positive predictions for the future. But what I'd love to know is that if you've got any thoughts on your work in particular and just the landscape in general in companies. So if you're someone listening to this that is a C-suite position or owns the company, or you're just a female employee in a company that would like your workplace to have more support and inclusivity around this, do you think that even if you actually mentioned earlier that your work, may or may not translate at a treasury level because that's obviously very difficult, do you think that when you start publishing what you find, it will help more companies to invest in female health because they understand that actually it'll be more profitable for them in the long run? Or what's your hope or thoughts there?
I hope so. Obviously, I hope so. And I'm quite optimistic because I think more and more employers are kind of open to the idea. Like the menopause definitely has opened floodgates in terms of, women speaking out and also employers kind of realizing that this is not just a health issue, but it's also a business issue.
Yeah.
So I am hopeful about that. I think the menopause has had its moment, and will continue to have its moment, rightfully so. But some of the areas that we need to start speaking more about, as we just discussed, I think our menstrual kind of leave policies, providing basic products in the workplace. And I think flexible working, but also knowing that flexible working can often be a cop-out. So just saying, oh, employees are able to work from home whenever they want, doesn't really cut it, because, I've spoken, and I'm sure you saw this in the survey. A lot of women are saying, well, yeah, I have to work from home because I have to be next to the toilet because I'm changing my pad every 20 minutes. But is that person really able to even work remotely? So I think being aware of those kinds of needs and being more open, and a lot of it is a cultural shift, because most women still aren't comfortable talking to their manager about their specific, quote unquote, women's health needs. Rightfully so, I think, because there is a level of fear of discrimination about, if I go to my employer and say I'm having a really painful period, I'm going to take the rest of the afternoon off. Will I be seen as just a woman? You almost don't, particularly in male-dominated environments, you almost don't want to point to any more differences between you and your colleagues. So there is a lot to do, but I am hopeful of. Employers and more employers recognizing that they have a part to play in this agenda.
I think what you just said there was really interesting, because I always just assumed women would want to talk about it in the workplace. It was just the environment, who they're talking to, their manager. And then I was chatting with a lawyer. She's awesome. She's a partner at her firm. And she was like, no, even if I felt like I could, I never would. And I was like, okay, interesting, just made the assumption that wouldn't be the case. So why is that? She was like, well, I wanted to be a named partner. Simple as that. She was like, any female health related stuff that's cropped up along the way she was like, I lie about it. I always lie about why I need a sick day if I need a sick day. And I was like, oh, sad.
Really sad. Really sad.
Mm.
But it still is seen as A, a taboo, B, a sign of weakness, probably. Because I think at the heart of this is that women say they're in pain, but oftentimes that's discounted. We're told we're being dramatic, or that, it's just in our heads, or come on, it's just a period. Women have been menstruating since the genesis of time. Just get on with it. And so if you're speaking out about it and your doctor is not taking you seriously, what do you think? Do you think your employer will take you seriously? Probably not. So there's a whole ecosystem at play here, and we all have our part to play in it.
That's actually a really interesting point, that if the doctor takes you seriously and you get a prescription, a diagnosis, whatever it might be, then obviously that gives you something to talk to your boss about. Of course, they're more likely to take it seriously, which I'm not saying is right, but it's come from the doctor. But if you're talking to your boss and they're saying, okay, well, what is actually wrong with you? Oh, well, nothing. There's no diagnosis, there's no whatever, because your doctor hasn't took it seriously or whatever, then of course the boss is going to maybe be less inclined to be like, okay, there's a more serious problem here. Yeah. Which I then guess comes back to the need for women's health hubs, where you actually have specialists in that and condensed appointments for a more holistic overview. When do you think, if at all, that we will see some of those? What would be your optimistic prediction for the future?
So some already exist on the ground. So even before the women's health strategy was announced, systems did have a women's health hub in place, even though they perhaps didn't call it that. So I believe at the time, or when the women's health strategy was published, they published a report around the kind of hubs that existed on the ground that fit their quote-unquote criteria for what a women's health hub is. So there were 17 on the ground. I'm curious as to, because of what I mentioned previously about systems kind of rescinding their funding, some systems rescinding their funding in order to break even. I'm curious as to how the definition of a hub might shift. So a lot of systems have been talking about their hub being virtual, so a virtual menopause consultation service, for example, which is an interesting idea. I know there is one in City and Hackney that offers virtual engagement experience events and virtual group consultations. So it's a menopause specialist meeting with 8 to 10 women at a time. And it actually works really well. So there is a space for these virtual clinics, but a lot of kind of what we're seeing in terms of what women need, having coils fitted, or some of these things obviously can't take place virtually.
Yeah.
But to establish a physical hub is quite costly. So it'll be interesting to see what happens. But I am hopeful. I think, I'm an optimist for sure. I know you are too.
I feel like you've got to be, otherwise why are you in this space?
Yes. There are certainly days, though, where you're just like, am I banging my head against the wall? Am I just fighting a never-ending fight? But I think it's always important to kind of take a step back and reflect on how far we've come. Like, even the fact that we're sitting here right now and having conversation about women's health, talking openly about periods and the menopause, I just think is a seismic shift that is not really quantifiable, but such a big leap. So it's always, whenever I'm feeling down, I do like to take a step back and think about how far we've come. And that gives me hope for how far we can go.
Yeah, amazing. Yeah, I love that. I know that there was kind of a few different talking points that we wanted to get to today, but we do only have about 5-6 minutes left where we started a little bit late. So what I'd love to do is, rather than ask the next question, is just see if there was any one area that you'd like to focus on more, in particular just over the last few minutes, if there was anything where you're like, I really want to get this point across or talk about this topic.
Yeah, so I guess maybe I can provide a bit of an overview or a brief overview of the research. So the report and the kind of project that I'm undertaking on women's health economics throughout England will have 3 key kind of facets to it. The first facet will look at women's health inequalities throughout England, because obviously we know women's health or women are not a monolith. So within women's health, there are obviously disparities based on socioeconomic status, location, geography, etc. So it'll assess the disparities within women's health throughout England. So that's strand 1. Strand 2 is a macroeconomic assessment of obstetrics and gynecology services throughout the country. Again, we know women's health is not just obs and gynae. We know that women's health spans far beyond that, but we thought this was a very natural place to start, given kind of all that's going on in gynecology and maternity services. So that will be the kind of what you mentioned before, the quintessential: for every £1 that you invest in these services, you can expect to see X pounds return on investment. The third facet of it will be a more kind of granular, longitudinal piece of research into certain conditions. So our focus for this piece of work will be on primary dysmenorrhea and heavy menstrual bleeding, so period pain, heavy menstrual bleeding, PCOS, the menopause, fibroids, endometriosis and adenomyosis, and infertility. I think those are, I don't know if I've missed any, but so what we'll do with those is we'll look at some of the things that we've talked about previously, where in a lot of cases, particularly for the primary and secondary dysmenorrhea and PCOS, women are kind of having to bounce around the NHS to get any kind of treatment, or even if they get to this point, a diagnosis. What does that look like in terms of their quality of life, their ability to go to work, to go to school, to undertake their caring responsibilities, whatever that looks like for the woman? How does that affect her ability to contribute to the economy? And then we also want to look at the cost of that to the NHS. So the cost of, a woman bouncing around, kind of going into multiple appointments, because that's a cost for the NHS, but that's also time that she's not at work or not at school or not, able to undertake her caring responsibilities or whatever that looks like. And also, if we can, and this is the part that's particularly interesting, if we can take a longitudinal approach to that. So, for example, if you're living with endometriosis or PCOS for 8 to 10 years, not receiving the proper treatment or diagnosis, how does that exacerbate things down the line for you in terms of your propensity to develop other conditions, multimorbidities, which are then much more costly to the NHS because there was no prevention, there was no diagnosis. So not only over that span of time are you not getting the treatment that you deserve, you're not getting, you're not being listened to, you're not receiving a diagnosis, or whatever the treatment plan looks like. But then there's also that longer term aspect to it, where I think it'll be so hard to quantify, but we should attempt to do something about that, because down the line there's so much. If we look at, I know we talked about PCOS, PCOS, so oftentimes someone would go into their GP for erratic menstrual bleeding. And PCOS is oftentimes seen as a gynecological condition, but it also involves insulin resistance. What else? Resistance, high blood pressure, cholesterol. Like, there are so many other elements to it. Propensity to develop certain cancers down the line. And so it's just a matter of like, okay, if we had caught this way earlier, what could we have done differently to prevent all of these other conditions kind of that resulted or were exacerbated by not kind of addressing this? Which
is such an important conversation.
Yeah.
I really do feel like we're just not, what's the saying, not seeing the forest for the trees.
Mm-hmm.
When you know what we know about how, again, PCOS being a great example, and this has this internal snowball effect where women are more likely to develop other metabolic syndromes or autoimmune conditions down the line, why are we not focused on prevention or at least addressing it early? Because we know that that's going to save money further down the line and result in a happier, healthier, more productive workforce. So as someone that works in prevention, nutritionist, fitness professional, the message of prevention is obviously a message I absolutely love. And I'm really excited to be armed with more statistics and research, so thanks to people like yourself to be able to kind of spread that message and get more people interested in actually being preventative with their healthcare rather than reactional at a consumer level with clients and at a corporate level to companies. So again, thank you so much for coming on and sharing all of that. What I'd absolutely love to do, if you'd like to, is maybe circle back round to this in a few months' time. Obviously, we were cut a little bit short for time today, so there's loads more I'd love to unpack with you, but also I think it'd be really interesting to kind of do a where are we now in a few months' time as a result of the stuff that you're doing and other people are working on, and we can kind of maybe have a little regroup and see what's changed in a few months if you'd be interested in booking that in.
Let's do it. Absolutely.
Amazing. For now, just finish off by telling the listeners a little bit more where they can find out about yourself, your work, if maybe that's inspired anyone to consider a little bit of a career change like yourself, banking to economics and female health. Feel free to tell people where they can find out a little bit more about you, your work and what you do.
Yeah, so you can find me on LinkedIn, Bridget Gorham, Gorham, and my Twitter should be the same. And feel free to reach out through DM. I'm always happy to have a conversation about this.
Yeah, thank you for that, which I can really testify to. That's not an empty offer because, we didn't know each other and I was like, hey, your work looks awesome. Please, can we have a chat? And here we are. So yeah, thank you so much for giving us your time and giving me your time on the previous calls leading up to this in order to be able to facilitate this. So yeah, again, I'm just super grateful and thank you so much for being here.
And thank you. Thanks for all the work that you're doing.
If you've enjoyed today's episode, it would be amazing if you could do us a massive favour and leave us a review and even if possible a comment. The reason why this is so useful for us is it allows us to know which type of content and which guests are best going to be relevant for you and your goals so that we can continue to make the podcast even better for you in the future. Thank you so much so far for all of your support on the Women's Wellness Show.